We're going to talk about depression. This is chapter 14 in your book, and we all know that there are normal variations in mood that can occur in just response to life events. So normal sadness, normal euphoria, anxiety, but they're all time limited and usually aren't associated with any functional impairment. When a sad mood interferes with daily life, depressive disorders may exist, and these patients may benefit from treatment. So let's get started here. Depressive disorders all share symptoms of sadness, emptiness, irritability, somatic concerns, and thought impairment. All of these symptoms significantly can impact a person's ability to function. Clinical symptoms of depression are very complex and dynamic. These patients experience a low quality of life and are at great risk for development of physical health problems than those that are not depressed. Depressive disorders are characterized by severe and debilitating depressive episodes and are associated with high levels of impairment in occupational, social, and physical functioning. A lot of times, this can cause a much disabled and distress as those with chronic medical disorders. Depressive disorders are classified as major depressive disorder, which is the one we're going to really focus in on this chapter, but there are other disorders like disruptive mood dysregulation, persistent depressive disorder, premenstrual dysphoric disorder, substance or medication-induced depressive disorder, and depressive disorder due to another medical condition. So let's look at each of those individually, and then we're really going to focus in on major depressive disorder. So disruptive mood dysregulation disorder was introduced as a response to an alarming number of children and adolescents being diagnosed with bipolar. This diagnosis resulted in exposure to really powerful medications and a lifelong label of a serious mental illness. You're usually going to see this diagnosis in children ages 6 to 18. Symptoms of disruptive mood dysregulation disorder are constant and severe irritability and anger. And the temper tantrums are usually well out of proportion to the situation at least 3 times per week. They also can exhibit symptoms in at least 2 settings: home, school, and with their peers. There is little information available on the treatment of disruptive mood dysregulation, but management for this population is symptomatic and problem-focused. If symptoms resemble depression, antidepressants would be considered. If manic episodes occur during antidepressant therapy, then bipolar may be a strong possibility. If ADHD symptoms are accompanied, the medications for that will be prescribed. Psychological interventions such as CBT, parent training can help parents interact that will reduce that aggression and irritability, and facial expression recognition training can all be implemented. Persistent depressive disorder is formerly known as dysthymia. Low-level depressive feelings through most of each day for the majority of days. In addition to that depressed mood, individuals with this disorder also have decreased appetite or overeating, insomnia or hypersomnia, low energy, poor self-esteem, difficulty thinking, and hopelessness. These symptoms are very difficult for the patient to live with, and they can bring about social and occupational distress, but they're really not severe enough for hospitalization. They may report that they have always felt this way, and really depression is a normal way of functioning for them. Later in life, this can become major depressive disorder. Premenstrual dysphoric disorder is a relatively new diagnosis. Symptoms cluster in that last week prior to onset of a woman's menstrual cycle and can include mood swings, irritability, depression, anxiety, that feeling of overwhelmingness, and then difficulty concentrating. These symptoms can be severe enough to interfere with a woman's ability to work or interact with others. Only about 2 to 6% of women have these symptoms, and they usually cease after menopause. Treatment usually includes regular exercise, high carb diet, relaxation, and then just making sure they're getting good sleep. Other depressive disorders that we have hit on are substance-induced depressive disorder. This is depression symptoms associated with the use of or withdrawal from drugs or alcohol. And then depressive disorder associated with another medical condition may be caused by disorders that affect the body's systems or from long-term illnesses that cause ongoing pain. So when we think about diagnostic criteria for major depressive disorder, they have to have either depressed mood or loss of interest or pleasure in nearly all activities for at least 2 weeks. In addition to that mood, 5 or more of the following also must be present: weight or appetite changes, sleep disturbances, fatigue, worthlessness or guilt, loss of ability to concentrate, recurrent thoughts of death, and psychomotor agitation. These symptoms occur almost every day and last most of the day. Other criteria for major depressive disorder includes persistence for a minimum of 2 weeks to 6 months. Chronic would be considered lasting more than 2 years. Recurrent episodes that are common are symptoms that cause distress or impaired function. This might be the presence of auditory hallucinations or the presence of delusions. Episodes not attributed to physiological affects. This may begin within about 4 weeks of childbirth and can include delusions, which could put that newborn at risk or harm. And then the last one is absence of manic or hypomanic episodes, which could lead to a misdiagnosis. Explanation of symptoms may be expressed differently because of language, or they may not seek treatment unless it is a provider of their own culture or ethnic background. So when we look at the epidemiology, it's the leading cause of disability in the United States. About 7% of the population are affected by depression, and that doesn't sound like a lot, but if we just look at our cohort, we have 47 in this cohort, which means about 5 of you have the epidemiology of having depressive disorders. When we look at the comorbidity, it's a combination of anxiety and depression is perhaps one of the most common. Approximately 70% of clients with depressive disorder have anxiety, which just puts them at higher risk for suicide and disability. The use of substances often is an attempt to relieve depression symptoms or self-treat mental health disorders. Depression in older adults is often undetected or inadequately treated. Depression is often associated with chronic illness. I want you guys to understand that depression is not a normal part of aging. So we can't just say because someone is getting older and that they're depressed. That is not normal because it's not a normal part of aging. We do see a disproportionate number of older adults with depression being more likely to take their own lives, which just shows again that this is not a normal part of aging. Some of the primary risk factors for depression include just being a female, that female gender, adverse childhood experiences, which could include divorce, it could include abuse, stressful life events, first-degree family members with major depressive disorder, neuroticism, which is that negative personality trait that's usually characterized by anxiety, fear, moodiness, worry, envy, frustration, jealousy, and loneliness. And then other disorders such as substance use, anxiety, and personality disorders can put you at risk. And then the last one, there's chronic or disabling medical conditions. Again, these are just primary risk factors for those that could have depression. When we look at our risk factors, biological factors is the most common risk factor. Interestingly enough, we do see that identical twins have a 50% likelihood they will both develop depression if one or the other does. So if you have an identical twin, I would be on the lookout for that. As far as biochemical, The two main neurotransmitters involved in mood are serotonin and norepinephrine. Deficiencies or imbalances of these will lead to dysregulations in our mood. Stressful life events seem to be a significant factor in the development of depression. When we look at hormonal, could also be a factor. Inflammation, which is just our natural defense to physical injury. There's growing evidence that psychological injury could result with inflammation. Support for this includes that about a third of the people with major depression have elevated inflammatory markers in the absence of a physical illness. So there's where your correlation comes. The diathese stress model we've talked about before, that's that interplay between genetics and biological predisposition toward depression and life events. And then cognitive, we'll look at here. Cognitive theorists believe that people may acquire a psychological predisposition to depression due to early life experiences. These experiences contribute to negative, illogical, and irrational thought processes that may remain dormant until they are activated during times of stress. So you can see Beck's theory there. You can also see the learned helplessness that's been defined for you. So let's move into our nursing process here. So when we start our nursing process, we always start with assessment. There are numerous standardized depression screening tools that can be helpful to help determine the type and the severity. Common screening tools are the Beck Depression Inventory, Hamilton Depression Scale, and the Geriatric Depression Scale. The PHQ-9 inventories predominant symptoms that are seen in depression. So the first thing we want to assess for is that assessment of suicidality. This is the most dangerous aspect of major depressive disorder, is that preoccupation with death. Patients should always be evaluated for suicidal ideations. The other thing that we want to assess is we want to assess ourselves. Patients with depression often reject the advice, encouragement, and understanding of the nurse and others. They often seem unresponsive to nursing interventions and resistant to change. If your assignment is to have a therapeutic interaction and your patient will not talk, you may feel like a failure. When this occurs, the nurse may experience feelings of frustration, hopelessness, and annoyance. So I also want you to be aware that if you spend a lot of time with a depressed patient, you may start feeling those symptoms of depression. So just being able to recognize that is huge for the nurse. So other areas that we can continue to assess include appearance. So grooming, dressing, personal hygiene could be very markedly neglected. Eye contact may be intermittent or non-existent, and posture tends to be slumped or hunched with their head lowered. Usually they're looking at the floor. As far as behavior or affect, otherwise known as inertia, wow, I'll get it right. Inertia, it's that abnormal lack of energy, which could result in psychomotor retardation. So movements may be significantly slower, facial expressions are decreased, their gaze is usually fixed. You may hear someone say vegetative signs of depression, which just are indications that there's an alteration to normal activities that are really necessary to support physical life and growth, like eating, elimination, sleeping, and sex. So again, right, we have to have that bottom part of Maslow, that physiological part of Maslow obtained before we can move up the chart or move up the triangle. As far as mood, depressed mood and anhedonia. Anhedonia is that reduced ability to express pleasure and things that you used to enjoy doing. Emotions could be anxiety, feeling of worthlessness, hopelessness, guilt, anger, or helplessness. When we think about thoughts or perceptions, a lot of times delusions or hallucinations might be present. And then our comorbidity could be chronic pain sometimes. So this is just a slide to give you a little mnemonic to remember depression assessment. You can see SIG-E caps. So sleep disturbance, interest is decreased in pleasurable activities and sex. That's that anhedonia. Guilty feelings, energy is decreased, or inertia. Their concentration is decreased. Appetite could go either way. Psychomotor function could be decreased, which is that psychomotor retardation. And then suicidal ideations is always key and must be maintain that safety. So now that we've gotten a good assessment, we'll move into the next step of the nursing process, and that is an analysis. So page 252, table 14.2, has a really great list of signs and symptoms that lead you to the priorities with goals or outcomes for each of these priorities. Remembering after we've done our assessment, we've collected our data, our primary priority is going to be safety. So we're always checking for that risk for suicide. Other ones that we can consider are chronic low self-esteem, imbalanced nutrition, constipation, disturbed sleep patterns, ineffective coping, and that disabled family coping. So assessment is complete, priorities are established. Now we set goals that are very specific to that patient and based off of their priorities. All patient priorities will be a little different, and each outcome has to be very patient-specific or patient-centered. We can use the recovery model when creating these outcomes, which just emphasizes that healing is possible and attainable for any person with a mental illness. Recovery tends to work best when we focus on our patient's strengths. Treatment goals are mutually developed, and it's based on patient personal needs and values. So let's look at some of these examples. I think actually I've taken the examples out of the slideshow, so we'll talk about these in class. Planning is the next step in our process. We have our outcomes, our goals established, and now how are we going to accomplish those? When we look at how we're going to accomplish these, we need to see what phase our patient is in with their depression. There's an acute phase, a continuation phase, or a maintenance phase. So what are their particular symptoms that they have, and what are those patient goals that we need to focus on? So again, before we can implement care, we need to determine what phase of care our client is experiencing. So if they are in the acute phase, which is usually the first 6 to 12 weeks of treatment, and treatment and recovery, this is where they're treating and recovering from that major depression. Potential need for hospitalization: if we're finding very severe clinical findings of depression, they're suicidal, they may need to be hospitalized. Once we have been able to reduce those depression symptoms, then their ability to function definitely increases. In this phase, in our second phase, continuation phase, which is that 4 to 9 months of treatment, this is where we're preventing relapse. And we've started pharmacotherapy, we've started education and psychotherapy. And the last phase is maintenance phase, which is usually about a year or more out. And this is remission of manifestations. And this phase, we're really preventing future episodes. So when we think about implementation, we can think about counseling and communication. Communication can be difficult with the patient that is withdrawn or unwilling or unable to speak, and they just sit there in silence. Certain techniques are useful in guiding effective nursing interventions, and so let's look at those. Some of the communication techniques we can talk about are using simple, concrete words. Remember, they have the inability to function, so we need to make sure that we're using simple, concrete words. Allow time for the response. There's going to be some silence in there, and we have to be okay with that silence. Listen for those covert messages, remembering that covert statements are those statements that tend to have the hidden meaning behind them. If the patient says, "It'll all be over soon," we would want to listen for those messages that might be hidden. Ask about suicidal plans, remembering if you ask, you're not planting that seed, you're just asking. If they're suicidal, they've already had that seed planted. And then when a patient is silent, make sure you're avoiding those direct questions. They clearly need that silence for a purpose. So don't fire questions at them and try to avoid those direct questions. And then make observations to reinforce that reality. If you feel like they've lost touch with reality, try to observe how they've lost it and what's indicating that to you. As far as health teaching and health promotion, this is the basic premises of the recovery model. Again, this model allows patients to make those informed choices. Promotion of self-care activities, remembering that grooming, appearance have probably been neglected for a while, so how can we promote those self-care activities? And then teamwork and safety is the last one we're going to implement, remembering that safety is always key. Suicidal precautions are usually instituted. So we also need to remember that all interventions must be patient-centered. So we talk about that milieu therapy. You've heard that terminology before, right? It's the environment. So we want to make sure that the suicide risk is being assessed constantly. We're implementing safety precautions or even that one-to-one observations. We want to make sure we're monitoring the patient's ability to perform ADLs and encourage as much independence as possible. We want to spend time with the client, make observations, and be patient with time of responses during those conversations. Maintain that safe environment. And then counseling can help with problem solving, coping abilities, changing negative thinking to positive, maybe increasing self-esteem, assertive training, and using available community resources. So let's talk a little bit about treatment modalities with our depression. Antidepressant therapy is an effective strategy for most cases of major depression. So choosing an antidepressant, you'll want to look at the following. What is the symptom profile of the patient? What are the side effect profile? If the side effect of a med is sexual dysfunction and you have a young couple that is sexually active, that patient is probably not going to stay on those meds if it creates sexual dysfunction. Or what about weight gain? Thinking about the patient that maybe already struggles with their weight. If we give them medication that's going to create more weight gain, they're probably going to stop taking it. So making sure you're looking at those side effect profiles. What is the ease of administration? What is the history if they've taken these meds before or if family's taken them before? And then we need to think about safety and medical considerations. So some of these antidepressants that we're going to talk about are our SSRIs, our selective serotonin reuptake inhibitors. This is typically the first line of therapy. There's usually rare risk of serotonin syndrome, but we'll talk a little bit about them. You can talk about our SNRIs. We won't hit a lot on this, but if the SSRIs are usually tolerated better than our SNRIs, so we don't see these prescribed as often. We will hit on our tricyclic antidepressants, which unfortunately have some anticholinergic adverse reactions. And then we're going to look at our MAOI inhibitors. So let's just look at each of those categories. So selective serotonin reuptake inhibitors, or SSRIs, is the first line of therapy. We like SSRIs because of the low side effect issues. There's less anticholinergic effects, so less dry mouth, no blurred vision, no urinary retention. But it is important for them to be consistent in taking those medications. These medications have a broad base of clinical use. They treat depression, but can also be used with anxiety. We don't use these medications with bipolar patients because of that increased mania potential. Adverse reactions, the number one common adverse reaction that patients experience may deter them is a decrease in sexual performance. So again, making sure if they're super sexually active, that would probably deter them from continuing to take their medications. Other reactions include CNS symptoms, agitation, anxiety, sleep disturbances. If the patient's not going to take a medication because of a side effect, we really need to talk to our patients about options that are available. Toxic effect, or that serotonin syndrome, is an overactivated receptor. Maybe we have too high of a dose or not compatible with other medications that the patient is taking. They could experience GI, cardiac, psychosis, muscle spasms, even excessively high fevers. So what do we do in this case? We have to discontinue that SSRI med prior to starting a new medication. Make sure you give it time to leave the system before you start a new medication. So this slide here I got right out of the book, and it really shows you signs and interventions for that serotonin syndrome. This can be very, very fatal for our patients. So as nurses, we have to recognize, we also have to educate on what are the symptoms that would cause our patient to need to call the doctor and stop their medications. And then what are those interventions that we might need to do. Last point that I want to hit on with this slide is just the client education. And I pulled this from your book, and it's just lots of patient and family teachings. So this will just really help you out when we start filling out those medication sheets that we have. So the next medication we can think about is our TCAs, or our tricyclic antidepressants, specifically amitriptyline. The therapeutic dosing is about 10 to 14 days or longer before they start to work. Full effect may not actually be seen for 4 to 8 weeks. So we need, once we can look for medications that maybe have worked in the past or that have worked with family members. We want to start low and slowly increase our dose. Neurotransmitter effects include the reuptake, or inhibit the reuptake of norepinephrine. Adverse effects are going to be anticholinergic effects that aren't serious enough or often transitory. Urinary retention and constipation usually require medical attention, and then weight gain could be a common complaint of those taking TCAs. So knowing those adverse effects, knowing the side effects, and educating your family on them, or your patient on them, before starting them. Because if they're going to stop taking them because of those side effects, then we need to find an alternative. TCAs can also cause hypotension and tachycardia. So if we already have a patient that has lower blood pressure, probably not a great med of choice. It's best to give these medications at night to help mask some of those symptoms while they sleep. As far as toxic effects, it's usually cardiovascular in nature. Tachycardia, dysrhythmias, myocardial infarctions, heart blocks are some big ones. So making sure you do a full cardiac workup before administering these medications. TCAs should be used cautiously in suicidal patients because they are lethal with our overdoses. Patients and family education should be done. Change positions slowly to minimize any dizziness or orthostatic hypotension. And then to minimize our anticholinergic effects, we might encourage them to chew sugarless gum or maybe drink 2 to 3 liters of fluid per day. Monoamine oxidase inhibitors, or our MAOIs, are the last medication that we're going to talk about. These medications have a huge list of drug interactions and food considerations. When we're thinking about why we give MAOIs, it's usually given if other medications for depression have not worked, and you need to give something for depression and bipolar. As far as adverse toxic effects, orthostatic hypotension, weight gain, sexual dysfunction, cardiac issues, mania behaviors can all be present. The potential toxic effect could be a stroke, seizures, or high fever, and we're going to have to gastric lavage to prevent serious cardiac issues. Hypertensive crisis can occur with MAOIs if they're mixed with tyramine foods. So we have to be very thoughtful with our education for foods and other medications that the patient can and cannot take with MAOIs when they are prescribed. As far as client education, we want to avoid foods that contain tyramine. Let me go to the next slide here. And this is your food list of all foods that would contain tyramine that you would have to avoid if you are taking an MAOI. I'm not going to read all of these, but you should be familiarize yourself with all of these foods. And then we also want to avoid all medications, whether that be over-the-counter or prescription. There's lots and lots of medication interaction risk. So you'll definitely need to talk to the provider before taking any other medications if you've been prescribed an MAOI. And again, this is just taken from your book, and it's a lengthy drug list that you should avoid if you are taking an MAOI medication. So this slide just goes over MAOIs. It has your drug names there: Nardil, Carnate, Marplan. And if you take the first letters of each of those are not popular meds. And things that you cannot take with them are listed there: barbiturates, TCAs, antihistamines, CNS depressants, antihypertensive, and over-the-counter cold medications. If you do take any other meds or eat foods that you can't eat and you're taking an MAOI, you can see exactly what's going to happen. Remembering that it focuses a lot on cardiac, so we need to be very intentional about not creating that hypertensive crisis. Some of the newer antidepressants that we can talk about are SARI, serotonin antagonist and reuptake inhibitors, norepinephrine dopamine reuptake inhibitors, and noradrenergic and specific serotoninergic antidepressants. And then the last one, two other new drugs are that esketamine, which initially dosed twice weekly for 4 weeks, and then we taper that to once a week for 4 weeks. After about week 9, the dosing could be every week or 2. So I think it's just nice if you have a patient that struggles with taking meds every day, this might be a good alternative for them. And then that last one there, brinaxolone, is the first FDA-approved medication for postpartum depression. There is an abuse potential, so it's only available to patients through a very restricted distribution program. And it's administered over 60 hours. That's 2.5 days of IV infusion. It's a one-time infusion, and it offers really rapid resolution for those depressive symptoms of postpartum. So just some new medications that are coming out that I just want you to be aware of. Other treatments for depression can include integrative medication, which is our St. John's. So St. John wort is a flower processed into tea or tablets, and it helps relieve mild depression. The thought is to increase serotonin, norepinephrine, and dopamine into the brain. It can be potentially fatal if SSRI or serotonin syndrome results. When we think about brain stimulation therapies, we can think about ECT, repetitive transcranial magnet stimulation, vagal nerve stimulation, and deep brain stimulation. So let's look at those real quick. So when we think about ECT, this is a procedure known as shock therapy. It's really long been stigmatized treatment that is really safer than ever. And can be remarkably effective in our patients with severe symptoms. So what it is just an induction of a seizure on our patient. You don't physically see the seizure activity because we give medications during the procedure to protect those muscles. It's most commonly used for severe depression and can result in about 80% improvement. I think that's huge. Suicidal thoughts improve with treatment. It can be very effective treatment that is underutilized because of the stigma that revolves around it. The course of treatment is pretty hefty, so 2 to 3 treatments per week, 6 to 12 treatments in the course. Informed consent must be obtained, and EEG and EKG are also performed, and the patient is typically under general anesthesia for this one. And this is just another little picture of our ECT and what's going to happen. Remembering it creates a seizure-like activity but we're giving meds to kind of help with that muscle contraction, so you won't actually see the seizure activity, but it's going to kind of re-stimulate the brain. Transcranial magnet stimulation is a similar idea as ECT. This is MRI strength magnetic pulses to certain areas of the brain. These pulses can go through the hair, skin, and skull, requiring less electricity than ECT. The patient's usually awake for this procedure and can typically resume normal activities immediately after. Some of the adverse reactions may be a headache and lightheadedness. They may have no neurological deficits or memory problems. Seizure is usually very rare, and most are mild, induced scalp tingling, and discomfort in those administration site areas. Vagus nerve stimulation, maybe you guys have already started seeing some of this. This is really a good treatment for epilepsy, and it just boosts the level of neurotransmitters. More research is being done with this treatment, but it's honestly kind of a great thing that's happening that just can help with depression. It's really just, again, stimulating that vagus nerve. Some of the side effects might be voice alterations, neck pain, cough, paresthesia, those that are listed there. But it can decrease seizures and improve mood, which is what we're aiming for. Deep brain stimulation is surgically implanted electrodes in the brain. It stimulates those regions identified as underactive in depression. It is a more invasive procedure than our vagal nerve stimulator. Electrodes are actually placed directly into the brain. So those are, it's a little bit more invasive, but again, we're helping to improve mood. The next treatment for depression we can talk about is light therapy. So when we think about light therapy, this is the first line of treatment for seasonal affective disorder, which we didn't talk a lot about. This is when our mood just deteriorates, like in winter months or in the season, right? We have really long, or we have really short days. It's dark when we wake up, it's dark when we get off of work, and people can become just more depressed during those seasonal times. Efficacy due to influence of light or on melatonin. So exposing the face to 10,000 lux light box for about 30 minutes once a day in 2 divided doses can really have a lot of efficacy for it. It can be effective. This can be as effective as medication for that seasonal affective disorder. And then the last one is exercise. So I think we probably all know, if we've ever had a little bit of depression going on, that exercise can play a huge role in our patients with depression. It really stimulates and helps dampen some of that mood. So then the last part of our nursing process is evaluation. We're going to evaluate, again, remembering that it's tailored to the patient's unique presentation. Basic self-care, thought processes, self-esteem, and social interactions is what we really want to process. And did we meet those goals? If we didn't meet those goals, what other interventions could we implement? So it's basically starting our nursing process over again. But we want to make sure we evaluate so we can reassess. And that concludes chapter 14. If you have any questions, you can shoot me an email or we can talk about it in class. Thanks, guys.